Grant Gillett, Chapter 5, is the Professor of Biomedical Ethics at Otago University in Dunedin, New Zealand. He is a Fellow of the Royal Society, the Royal Australasian College of Surgeons, and of the Hastings Centre. His research ranges quite widely in bioethics, philosophy, and neuroscience. In bioethics, he works on end-of-life care, complementary and alternative medicine, autonomy, and the patient's journey. In neuroethics, he has written widely on brain birth, brain death, PVS, and minimally conscious states, and issues of free will, identity, and responsibility. His work in neuroethics arose from research in the philosophy of psychiatry, focusing on the nature of mental disorder, psychopathy, and dissociative disorders. He has examined these topics through post-structuralist philosophy, an exploration of the patient's voice, post-colonialism, and human subjectivity, and has authored Subjectivity and Being, Somebody, Neuroethics and Human Identity, Bioethics in the Clinic, The Mind and Its Discontents, Reasonable Care, Representation, Meaning and Thought, and co-authored The Discursive Mind, as well as numerous articles in a variety of international journals. From Aristotle to Neuroscience, The Human Soul is his most recent work. This is taken from Tensions and Traumas in Health Law by editors Ian Freckleton and Kerry Peterson, published by the Federation Press, 2017, and yes. Chapter 5, Ethico-Legal Dilemmas in Clinical Service Delivery, Continuity, Recognition, and Relationships in Clinical Service Delivery. Grant Gillett. Introduction. The relationships between healthcare professionals and patients are evolving under the joint influence of biomedical ethics and health law. From doctors being seen as authorities and patients as needy individuals to a more effective sharing of power. Patients used to do as they were told, but the concept of patient autonomy has become prominent in ethics and medical law, to the point where some would lament the passing of the role of the doctor as a wise and benevolent caregiver. Therefore, the current ethical perspective plays the four principles relatively piano and the doctor-patient relationship relatively forte. It implies that medical jurisprudence should distill an evolved set of expectations of healthcare delivery based on the experience of patients rather than abstract ideals formulated within either a paternalistic or quasi-contractual framework. Some argue, given the rise in emphasis on autonomy, that doctors are technicians using their skills to meet the demands of patients on the one hand and certain non-Hippocratic demands, either from the bureaucratic system or from a commercial domain in which profits or yields on investment become part of a dominant business model governing healthcare, on the other. Arguably, however, the needs and vulnerabilities of patients are more or less the same as are the virtues characteristic of a good healthcare professional, so that there are significant continuities with ancient writings and contexts in the need for care and concern for the patient and the continuity of care during the illness journey. In the changing clinical world where medical values seem to respond to political and social forces beyond our control, it is hard to keep a head and heart attuned to those enduring professional virtues in the midst of dynamic and shifting tensions of the type found in contemporary healthcare. That continuity calls for even more clarity of mind about the professional-patient relationship than we have shown to date in our ethical and medical legal thinking, and makes the current ethical analysis closely relevant to certain aspects of health law. 1. The duty of care. 2. Joint decision-making and responsiveness to the patient's illness journey. 3. Confidentiality and the proper inclusion of others in a care network. 4. Disclosure and adversarialism. And 5. End-of-life decision-making. Each fits within a framework of virtue as the basis of a professional life in the clinic. The framework. Joe is considering having a semi-elective procedure for a troublesome condition. In the process of obtaining consent, the doctor comes to the section about risks and breezily mentions that there is a 90% chance of a good outcome. Joe, like most people, chooses to go ahead with the procedure. If the doctor had instead told Joe that there was a 10% chance of a bad outcome, Joe would have chosen not to go ahead. This case, based on an actual study of patients' choices by Andrew Lloyd in 2001, shows that the way we assess odds is not rational, but often based on incidental conversational factors, e.g. framing effects. It suggests that the myth of conscious rational autonomy is on shaky ground in the clinical sphere. We are strangely irrational and unduly influenced by factors we do not completely understand, even if they seem to be consciously apprehended. However, things are not quite as black as the worst reading may imply, because most actions and decisions arise, in clinical life at least, from conversations involving negotiation. Decisions take shape in a dynamic flow of thinking that should give effect, as far as possible, to a person's story as he or she chooses to live it. They shift according to the demands and possibilities emerging in clinical consultations seen as problem-solving exercises to which patients and professionals each bring their own distinct contributions and try to align their judgments with each other. The skills arising from that learning link people in a specific way to the truth of their situation and help them to take care of themselves. Foucault gives this characterization as a key to the nature of ethics in his Ethics, Subjectivity and Truth, edited by Rabinow. Decision is therefore not a circumscribed event in time, autonomously initiated by one party and efficiently concluded. In fact, the psychological skills required are fostered in the process of being informed and engaging with a health professional about one's predicament and its treatment. The fluidity of clinical decision and action, therefore, dovetails with abilities to react and respond intelligently within a clinical conversation about one's life plans and current interests. A kind of deliberation, to use an Aristotelian concept, leading to a form of supported autonomy appropriate to life challenge. The role of the healthcare professional as a trusted and trustworthy companion in this interaction means that rational autonomy has to take adequate, down-to-earth and fuzzy account of what the professional brings to the table. The internal morality of medicine. In caring for patients, we begin with the Hippocratic scenario of a single professional, the damaged or at-risk patient, and a regimen of care. An analysis of ethico-legal tensions in contemporary clinical medicine can usefully trace the evolution of clinical relationships from the marked imbalance of the traditional model of the expert and a dependent patient, using an ancient metaphor of the patient as the owner of a ship to whom the physician, captain of the illness voyage, is answerable. The Hippocratics were alert to the complexities of clinical life, especially the discomfort of a patient. Physicians come to a case in full health of body and mind. They compare the present symptoms of the patient with similar cases they have seen in the past, so that they can say how cures were effected then. But consider the view of the patients. They do not know what they are suffering from, nor why they are suffering from it, nor what will succeed their present symptoms, nor have they experience of the course of similar cases. Citing Geoffrey Lloyd, Hippocratic Writings, page 142. The image is apt, even though the internal morality of medicine has developed complexities beyond the Hippocratic philosophy, as medicine has transitioned from a private good as we construct a form of social and political responsibility for the health of our societies. The growth of the clinic, described by Foucault, citing The Birth of the Clinic, an Archaeology of Medical Perception, has created an institutional health service in which medicine regards the patient as a target object of technological and scientific healthcare interventions themselves, in a contemporary context, open to increasing capture by major health industry players. Citing Journal of Bioethical Inquiry, Problematizing Biomedicine, 2010. The relative disempowerment of patients has been highlighted in Australasia and elsewhere as a moral crisis in which abuses of power in healthcare should be overcome. The relative disempowerment of patients in the latter half of the 20th century concerned many, but that it led to abuses and that these were not well dealt with by existing mechanisms for clinical research is an issue illuminated by the lived experience of a medical student of that time. Citing Grant Gillett, Living and Learning at a Time of Moral Crisis in Medicine, 2011. As a clinical medical student, house officer, and then a registrar in the midst of the events that later came under scrutiny in the Cartwright report, reflections on the duty of care for the patient seem to indicate a need for the reform of medical ethics, the philosophy of medicine, and the medical establishment. The relevant experiences cast a light from within on a proud and principled profession as it existed in many parts of the world in the 1970s. Senior medical figures occupied key positions in multiplex relations of power and influence, often fueled with dedication to their work and commitment to their ideas about the best ways to treat patients. But patients and their concerns seemed somewhat marginal. But the internal morality of medicine and the ethos sustaining it proved deficient because of lack of systematic seeking of consent to inclusion in research or to treatment, except for operative procedures, and inadequate procedures for approval and surveillance of both, and patients not being properly informed of the treatment options available to them, and poor professional relationships which contributed to the failure to put patients' welfare first, issues of concern to medical and law graduates from that time. Internal morality, those values, norms, and rules that are intrinsic to the practice of medicine, brought the problem to light and limited the harm to patients. Policy makers subsequently imposed an external morality, societal and quasi-legal regulations that made the system less person-centered and caused significant resentment as an external constraint on doctors and their roles in healthcare. By contrast, a more caring, complete, and inclusive response might have promoted partnership as a way to foster the well-being both of patients and the healthcare professionals entrusted with their care. Partnership means that patients and doctors must change, sharing responsibilities as well as information and decision-making. It takes two to tango. Medicine's ethos focuses on the good of patients, and since Hippocratic times, has guided professionals so as to protect patients against harm. At times, the outcry against the medical establishment has fueled allegations that it tends to close ranks against the patient's rights-based critique. In many countries, including in New Zealand, independent ethics committees and patient advocates, chosen in part because of their non-alignment with the medical profession, have tried to counterbalance the medical paternalism that can dominate existing clinical contexts and professional surveillance mechanisms. But no bureaucratic reform in and of itself can transform the patient journey and properly recognize the need for trust and trustworthiness in a well-functioning healthcare system and those who care for patients. The illness journey. The journey metaphor allows us to understand what is going on for a patient when disease lands them in the badlands of human life and well-being, the land of clinicum, the specialized domain of healthcare and its workings. In that setting, one is off one's turf and needs to learn skills of judgment and mastery of difficult areas of thought and action so that healthcare professionals, ideally, should not merely elicit information or informed consent from a patient who struggles to gather and assess the relevant information. A healthcare professional should provide the knowledge and emotive support that makes the decision meaningful and accessible to the patient so that shared decision-making within an open-ended clinical conversation can engender trust and a responsive mode of information sharing that enhances the patient's ability to understand and use the medical evidence. Autonomy then results from an interactive process, structured by interpersonal skills of argument or reasoned discussion, conducive to self-formation as a traveller on the illness journey. The traditional view of autonomy, in which a person comes to a decision based on their own processes of means-end reasoning, suggests that such a decision should reflect a view of the world, however deficient, within the bounds of reasonableness. On that view, a person acts autonomously as long as he or she does what, consciously, he or she opts to do. A naive view of the human condition, especially when we consider the asymmetries, vulnerabilities, and the need for trust in healthcare. The dignity of the patient then becomes a constant, based on recognition of their unique human standing and one always to be respected, regardless of their decision-making capacity and cognitive attributes. Conversations illuminate the significance of a clinical situation, as those who are conversant with the twists and turns that an illness journey may take respect the narrative of others and enable them to appreciate the realities of an illness and its management. That allows everybody, including a patient, to create an illness story with integrity, rather than being a medical object dealt with by others or merely a functionary. Being connected to the medical truth, one could say, enables both staff and patients to be agents with distinctive sets of values that ought to be respected. Such reflections on clinical decision-making blunt the unsettling criticism that autonomy and informed consent, as usually conceived, are illusions. Healthcare professionals both support well-being and attend to the aspects of illness that often get overlooked if they are trusted as expert companions familiar with diseases and helping patients to prepare themselves for what lies ahead. The Hippocratic recommendation. Such expert companions make open-ended contributions whereby a patient is not abandoned and the illness becomes less of a struggle and more of a development of the self. Humans readily relate to the metaphor of the physical journey, with the body as the vehicle of travel. It is peaceful, future-oriented, focused on the process and the means, open to new positive opportunities, and devoid of confrontational references. In a hostile world where one must be vigilant for danger, but that mode of being in the world is both stressful and affects many bodily processes in an adverse way. Yes, one must be vigilant for danger, but that mode is stressful and is adverse to the body. The framing of any illness in terms of a development of the self in the face of a challenge, a time of growth and restoration in which wholeness can be recovered, and the finding of new meanings rather than intrusive and unsettling fears and anxieties, encourages restoration and rebuilding. The ancient Hippocratic advice about equipping and empowering patients to better endure the illness journey with an intact sense of self and well-being then becomes highly relevant. After illness, one hopes for an integrated self, adapted to the world in which one lives and moves, and has one's being, or alternatively is prepared for a good death. Humanness and the sense of being a fellow traveller in life's journey is therefore a key quality in the land of clinicum. It potentiates our becoming trusted companions on trying journeys, and a refusal to be dismayed or to abandon our fellow human beings can inspire a healthcare team to stand by a person in need. What is more, some knowledge of the holistic nature of the healing relationship allows us to explore the top-down effects on bodily processes when a person is recognized by a fellow traveller or travellers, and their journey witnessed, so that what has to be borne with courage and resolution, and the rediscovery of self, as important in one's own healing, becomes part of a joint enterprise. A health companion is like a resident placebo, or healing presence, exerting a therapeutic effect on the patient by standing alongside the one who suffers. The companionship and humanness of the well-managed illness journey poignantly evoke the African motto, "I am because we are, and because we are, therefore I am." But this ethic embeds a special form of sharing, caring, and helping whoever is in need, which some African thinkers know as Ubuntu. Philosophy embracing the intertwined nature of human lives and the importance of relationships. Somebody who says, "Lean on me," is a vital part of this picture. And there are times when we need to be able to say that ourselves to complete the circle of life. Medicine and scientism. In Western societies, medical truth draws on scientific discourse and its institutions, a context of constant economic and political incitement, circulated through apparatuses of education and information, which produce and transmit medical knowledge under the auspices of a political and economic apparatus, that it is the focus of a complex debate and social confrontation. Citing Michel Foucault, the Foucault Reader, page 73. We can take these in turn. The movement towards evidence-based medicine, EBM, with the undeniable gains it has provided, has recast medical knowledge towards unidentifiable effective interventions that are given high status, embedding a model of health and disease tied to standard remedies. That focus shifts clinical explanation and the ends guiding diagnosis to a focus on the episode and a critical intervention or best practice guidelines. Such scientific medical thinking and low-level medically influenced advice and pop wisdom pervade our society. Magazines, television, films, and advertising, all evincing a soundbite or news headline orientation that dumbs down illness and its management. Condition X is treated by drug Y from company Z, or an intervention that produces change in a similar time frame. The alliance between major pharmaceutical concerns, institutions performing medical research, regulatory bodies setting standards for healthcare, and the profession forms a multifaceted political and economic apparatus, reinforcing the model and its well-grounded claims to nearly all the major advances in healthcare, particularly in the 20th century. Good quality care can, as a result, be seen as using the latest and most expensive medical technology applied according to protocols, undermining clinical acumen, the mark of an experienced physician using an artful regimen adapted to the many challenges of any illness journey. But such a conception of good clinical practice can leave even very experienced clinicians exposed to medical legal risk if things do not turn out well. Modern medicine is therefore a discursive regime bolstered by science and the political weight of the profession, dominating debates about healthcare in any developed society. The regime creates a taxonomy of disease and a range of approved interventions. Thus, medical science, like all science, is a site of revolutions in which old paradigms are attacked, ravaged, and discarded or abandoned through creeping disaffection as new paradigms take their place. Thomas Kuhn, in The Structure of Scientific Revolutions, noted that paradigm shift may not merely reflect debates within the logical structure of scientific knowledge, but also the ethos of the age and historical curiosities such as the rise of holistic therapy, in which detailed molecular and pathophysiological processes are only part of the medical theory, and the holistic aspects are deeply problematic for the biomedical paradigm. Foucault identifies not merely a set of competing scientific claims as theoretical constructions, but rather a regime of knowledge governing what counts as legitimate science. His and related critiques potentially reshape our thinking about human beings, their health, their reproductive activity, their diseases and their sanity, along with the socio-cultural and political influences that bear on clinical practice and its legal climate. The biopsychosocial model of medicine. The biopsychosocial model by George Engel, The Clinical Application of the Biopsychosocial Model, 1980, is an attempt by clinical medicine to accommodate this challenge and encompass broader explanations of disease and health. Thus, for instance, we understand hypertension as contributed to by stresses in a person's life, such as financial insecurity, threats to relationships, uncertain vocational future, shifting life to a new neighborhood, city or country, and so on. But that opens up ways of thinking and managing disease that are not scientifically proven in the ways we are used to in assessing our duty of care and the level of skill expected of a clinician. In effect, it encourages a kind of humility about medical technologies and interventions because they are problematized. Wherever old certainties are under attack, like the role of cholesterol or statins in heart disease. What are the limits of professional responsibility when we promote preventive measures like immunization that may be regarded as being intrusive and unprofessional, and the discriminatory overtones of complex problems like obesity? Certain genes allow human beings to thrive in relatively nutrient-poor, exercise-rich environments where most of their fat and glucose comes from fruit, vegetable, and seafood sources. But the same genes may lead to obesity and type 2 diabetes where salt, fat, and glucose are relatively available and minimal exercise will obtain maximal nutrition. Approaches to illness focusing on psychosocial as well as biological factors in managing clinical phenomena such as pain, medically unexplained symptoms, mild psychiatric illness, and so on, might be important in understanding disease and comprehensive clinical management, but given the constraints of modern healthcare and medical research funding, those issues may evade well-structured investigation or normal medical science. We know, for instance, that the neural pathways for pain and distress are complex, and their role in the control mechanisms of a human organism make it difficult to delineate the scope and limits of competent practice. In such uncertain terrain, a restricted clinical and scientific gaze aiming for objectivity and robust knowledge may be confounded, and along with it, clear ideas about causation and cure. Many clinical service areas impinge upon socio-political realities, so fraught that it is difficult for medicine to disentangle itself from social activism. For example, asthma in disadvantaged children living in surroundings with damp housing, unsanitary conditions, overcrowding, and poor nutrition represents a cry for social justice and a societal will to address inequality, rather than intensified and focused biomedical attention. Diseases of childhood are linked to poverty and not much help by new whiz-bang asthma drugs or this or that new technology. But a doctor who focuses on social change and does not focus on the biomedical route may be marginal in terms of good practice as defined by the biomedical industrial research regime and its funding. Social conditions, including the economic incentives influencing diet and lifestyle, are neither able to be changed as part of delivering healthcare services, nor usually included as important features of health science, because they are often thought to concern mainly social development or economics. But a doctor caught in this confusing territory may not be able to clearly negotiate the medico-legal complexities of good practice, certain aspects of which, as practiced by scientific medicine and pediatric opinion leaders, may look like rearranging the deck chairs on the Titanic. Ethics and paternalism. In the old days, a disease posed an intellectual, scientific, and professional puzzle for a doctor, and although patients suffered from the disease, they did not really play a part in what was decided about their management. Biomedical ethics in the latter part of the 20th century has changed all that, in ways that should be reflected when judging the quality of care. The doctor knows best what ought to be done, and a regimen can be judged according to whether it has been delivered in a proper and timely manner. Ethical reforms in terms of patient autonomy and the partnership model meant that doctors had to take seriously what patients wanted, what they knew and thought about their disease, and what role they were enabled to play in management. The patient should be respected and consulted. Patient compliance with the doctor's instructions, an arrangement that greatly simplifies determinations of causation of harm, has been replaced by a relationship of cooperation and mutual respect in which each has to trust the other and contribute towards an improvement in health for the patient and a lessening of stress on the doctor. The patient's voice reflects, perhaps, the wisdom of the body. Each patient is different, biologically and especially psychosocially. In fact, patients often know a lot about their illnesses and the kinds of thing that they can tolerate or even benefit from. That creates a gap between pathophysiology and effectiveness of a regimen of care, so that doctors can sometimes best design effective treatment by asking the patient about their response to a suggested regimen. The patient's feelings may reflect something they intuitively know about themselves. The advice ultimately given is also tempered by deference to the patient's thoughts about an illness, and the evidence may change, become firmer or less clear, sometimes at the speed of the internet, and revelations about faults or fraud in clinical trials. A proposed regimen of clinical care can therefore be cast in quite a different light from that in which clinical assumptions and judgments were originally made. The patient's perception of the regimen may affect its efficacy. The placebo effect is the beneficial effect of a medicine thought to be effective by the patient, and it plays a part in the role of any good doctor. But its efficacy means that patient attitudes, and, for instance, their trust in their doctor and the remedies offered them, may play a major role in the efficacy of clinical management. All these factors complexify what is often called the art of medicine. The art of medicine, creating a fault line in the science of biomedicine. But our philosophy of medical science and the assessment of competence and the adequacy of clinical services delivered struggle to take account of that gap. But that has got to be done, so that we need to reflect on how well we deal with evidence concerning a succession of private and variously respectful conversations, time pressure, and somewhat malleable human recall of that body of evidence. An intelligent therapeutic partnership formed with a patient who is on a journey which is deeply challenging and unsettling suggests a model of clinical care in which information sharing is vital. The doctor should be responsive and supportive as an expert partner with a clear eye on what is proven and what is contestable among the complexities of modern medicine. One's co-workers are one's strength, but when those relationships break down, we have to make judgments about what happened and what should be done to remedy, as far as possible, the harms caused despite the picture of events often being murky. An approach based on the illness journey and the healthcare professional as companion on the way can more adequately weigh what is right in relation to the individual patients treated and sometimes harmed by the medical system and the professionals caught up in that system. Lawsuits picture a practitioner wielding a body of certain knowledge with variable skill and care and an agenda which is distinct from that of the patient for multiplex reasons. Therefore, they can reasonably distinguish between the role of the patient and that of a doctor alleged to have failed to meet the standards of good clinical care. The resulting disputes are expensive, time-consuming, and damaging for all, and may well, in the contemporary healthcare environment, be inconclusive. As such, they can frustrate those interested in healthcare reform and those who try to do the right thing. Patients seek manifold forms of accountability, many of which are predominantly non-monetary in nature. Citing Bismarck, accountability sought by patients following adverse events from medical care, the New Zealand experience, 2006. The actions taken during such a confrontation, regardless of the finding and whether it is an explanation or a change in protocol, attempt to provide different types of accountability, such as correction, communication, restoration, and sanction, rather than focusing on retribution for a wrong or any other simple medico-legal formulation. Respecting and responding to these needs is an act of caring for patients in and of itself. We often get the emphasis slightly wrong and neglect the patient's right to feel that the responsibility for what has happened has been properly assigned and that the risks and dangers of it happening again will be rectified. When patients are provided with information and support and are enabled to understand what ails them and what is being attempted on their behalf, they have an opportunity to voice their concerns and have them responded to in a substantial and meaningful way so that the result is development towards safer care. Such developments change systems of care, enhance relationships, and improve understanding between patients and healthcare professionals. thereby bringing about better and safer care in ways that can be difficult to achieve in a medico-legal context where financial compensation and adversarial claims are the only options for resolution after harm. When that is so, apart from the day in court, the ongoing and other needs of patients are not sufficiently met, nor are their voices heard and acted upon in order to make real change and improve the climate of healthcare. Beyond that, the possibilities for a radical shift in ethics and medical jurisprudence can be explored through the lens of post-Holocaust moral philosophy, in which a human being is seen as one who calls us into an open-ended responsiveness, grounded in hospitality, and who comes to us as a stranger who arrives at our door. Citing Emmanuel Levinas' Basic Philosophical Writings, asking of us that we can be trusted to play our healing part in his or her journey. "Hey Joe, what brings you along today?" Joe is welcomed in a way that implies recognition. Perhaps he has bronchitis, pneumonia, and pleurisy. Medically speaking, almost all episodes of bronchitis cause some pneumonia, and almost all pneumonias involve a touch of pleurisy, and they all often respond to antibiotics, if caused by bacteria. But Joe constructs his illness as an immanent reality, and a puzzle. Is this related to my woodworking? Am I going to have to stop my French polishing, which I am just becoming proficient at? Is this something to do with my new belt sander? Will I mention that? The illness inscribes the suffering individual, and he constructs it along with a value or effect attached. Joe, if asked, "Have you ever had a serious chest infection?" might say yes if told previously that he had a bout of pleurisy or pneumonia, but not if he was told in a certain tone of voice, "It's just a touch of bronchitis," or if told virtually nothing and just treated. The tone of voice and the conversation convey to the patient the ontological and existential significance of his state of knowledge about himself and what is happening to him and his future, achieved in a clinical partnership. Such are the realities of our encounters in healthcare situations, constituting stories to be told and reflections to be engaged in, all coming from multiple different perspectives and sometimes subject to exclusive knowledge couched in inaccessible terms. Because of their existential significance and the fact that the language is that of another culture, clinicum, many aspects of clinical encounters are not accessible or comfortable to patients, so that they only find peace by deferring to their medical parents. The relationship they indwell can be, for that reason, quite unbalanced, even infantile, and subject to the intense emotions, vulnerabilities, loyalties, and perceived betrayals that color the life world of a child. In clinical life, we rely on trust for an almost instant entree into the sharing of worlds with another person, but the sharing is very asymmetrical. As one sees what is at stake for the patient, the one who suffers, the encounter engenders special duties of care based on the life and values of the clinician, but needing constant awareness of the fear and trembling of the person being whom the disease has summoned to an ordeal, only partly apprehended and with an uncertain, morbid, and possibly mortal significance. In the clinic, where the patient presents with their broken story and reveals that their life has strayed from the path they thought themselves to be on, we aim to move towards healing or making whole again through personal growth and restoration of health in the company of another, even if the path of care is going to end in death. That opportunity is reciprocal. It challenges both the professional and the patient. It is an open-ended opportunity, because in any clinical encounter, two worlds meet and stories of courage, pain, despair, trust, joy, and so on emerge. The structure and operations of power in the clinic minimize this actuality and reduce it to a legitimated clinical memory according to the medical paradigm. But sometimes the subject who is living the story needs more recognition. A reflective practitioner notices what is happening, and the ethical practitioner responds in a way that is fitting in the context of the relationship that has been formed. What is fitting tends to wholeness, or opens the way for the human subject to work constructively, rather than perpetuating a broken story and the regrets and recriminations it engenders. That is particularly so where the problem-solving mode of modern biomedicine is not appropriate for the story one is hearing. Usually, the physician knows much more about the medical condition of the patient than anybody else, and therefore the patient naturally looks to the physician for the most complete information about what is going on. For this to work in the nuanced way that real people need, the patient must trust the physician, but often the patient does not get to see her investigations or her notes. The implicit message is that the information belongs on the powerful side of the medical relationship and should be controlled by the doctor or the system. But this is not always the case. Consider Bill, a bluff former deer stalker who is now a shopkeeper in a rural town, and a patient with hemifacial spasm, a condition which screws up the side of the face so that the patient is often taken to be winking at people to whom he is talking, much to his or their embarrassment. This condition causes frequent misunderstandings, particularly in a shopkeeper, and he wanted to be rid of it. The operation is a microvascular decompression of the 7th cranial nerve, which innervates the muscles of the face. The operation carries a 25% risk of ipsilateral deafness. Bill had the operation but did not completely lose his tic. However, he did lose hearing in his left ear. He was presented and discussed at a clinical meeting of a group of neurosurgeons and neurologists. One of the neurologists asked how Bill had felt when he realized he was not free of his tic, but had in fact become deaf in 1 year. Bill said, "Well, I accepted that because I was warned about it before the operation, and what's more, the warning was a bloody sight easier to understand than what you jokers have been saying." There is more to this dynamic here than the accessibility of the language. Bill clearly felt that he had made a reasoned decision, but even more he felt he was in it together with his neurosurgeon. Often that does not happen, and that single factor seems to be the most important reason why doctors are sued. Citing David Warren, Medical Malpractices in the United States of America. Often, a clinical interview is all in terms familiar to a doctor, and the patient feels none the wiser, and perhaps confused by being told about things not really understood. This problem can only be overcome by the clinician realizing that the patient has strayed into confusing badlands and needs a trusted guide so as to regain confidence in his or her own ability to take part in the clinical decision. For instance, by being shown their x-rays and feeling that they can appreciate the problem they face. Even that simple information sharing shift towards partnership, something many clinicians are increasingly taking up, achieves several things. 1. Tells the patient that their medical information is accessible and that they can take an intelligent interest in it. 2. Allows the patient to actually see, in their imaging and its need for intelligent interpretation, the difficulties and uncertainties involved in diagnosis and treatment. 3. The doctor's openness about the evidence tends to dissipate rather than increase the stress on patients, just as one feels less stress the more one understands where one is on a trying journey. 4. It gives the patient permission to inquire about their tests and their treatment. They have, as it were, been invited across the gap, dividing them from their own medical information. 5. The patients find, often to their surprise, that they can, to some degree, understand what is going on, and as a result feel able to claim some ownership of the decisions being made. 6. Because ownership and responsibility go hand in hand, clinicians sharing information and the burden of decision-making relieves a major source of stress generated by difficult clinical decisions as it is experienced by a doctor. If we adopt an open-handed attitude in clinical situations, it is possible for patients to learn more about their treatment options and be more active partners in designing their regimen of care. This empowerment allows them to assume some control over a medicalized part of their life story, and it gives reality to the problem-solving alliance. It means that relevant decisions cannot be made absent the patient. Recommendations have to be formulated as clearly and considerately as possible, Uncertainties have to be shared, and we have to be open to the possibility that the outcome or the process chosen to try and get there may not be exactly as a clinician initially plans. Only then can the participation of the patient become a reality in clinical life. The advantages of such an approach are legion. They include the fact that the patient becomes an educated observer of his or her own illness and its management, and therefore a co-traveler on the path of therapy and its co-designer. An imaginary neurosurgical treatment recommended for the sufferer of a brain tumor, call her Rosalind, brings the issues into clear focus. Will she take the risks and side effects associated with surgery? There's particularly an attempt at extensive removal and possible paralysis of the limb, or depending on its location, loss of speech, or will. She refused an operation, given that it cannot cure her. Empowerment enables patients to decide on the best option for them as they view their choices and risks, all things considered, whether their problem is a malignant brain tumor or chronic pain. Any course of treatment involves conflicting considerations. There are some diseases where, in Hippocratic terms, a man is attacked by a disease more powerful than the instruments of medicine. In such cases, the experienced clinician often refuses to proceed, but many cases are less clear-cut, and the landscape is contested. We can communicate these uncertainties in such a way that the patient realizes that the problem is taxing, the decision is difficult, and a good outcome cannot be guaranteed. However, the clinical relationship cannot embody trust and companionship if the patient is offered no more than a highly edited and selective glimpse into a complex and kaleidoscopic situation, glossed by false medical assurances that we have it all under control. Real empowerment actually enables patients, through responsive and rational cooperation with clinicians, to devise a management plan that leads to the outcome most congenial to their own perceptions and values. Only then can patients take some responsibility for their own health care, and when properly included in a fitting way, they can do so better than by loading them with complex information, giving them little help with that information, and leaving them to choose, autonomously, this or that possible, or even wishful, escape from their dilemma. A narrative approach and empowerment. Narrative ethics and the journey metaphor go beyond informed consent and clinical care, offered with due care and skill, to take account of the power differentials that distort professional life and can silence those traditionally disempowered by an institution and its discourses. The language of autonomy, beneficence, non-maleficence, and justice, to which some would add dignity, sometimes does not throw these points into sharp relief, because they fall short of recognizing the dependency that is part of all clinical care, so that patients still feel lost in clinicum. A narrative approach can align doctors and patients as they navigate the illness journey, and does not implicitly put them on opposite sides in claims about rights and duties. Deconstructing such situations often shows that there may be no intention to marginalize the patient by those who hold medical power, and that in fact, the powerful players may not even realize what is taking place in terms of the dynamics between them and their patients. But nevertheless, the patient may have felt that they were denied knowledge or coerced into a decision because their story was not heard. Murray suggests that narratives put us in touch with stories and images of good, fulfilling, many meaningful lives. Even if the stories of clinical practice are not as self-driven as the patient would like, and mainly give us a glimpse of the lived experience of a person who is feeling vulnerable and who needs somebody to lean on. The empowerment of patients forces doctors, and particularly specialists, to relinquish some control of clinical management and ushers in a much more cooperative and ultimately satisfying adventure, which, to be sure, still has sticky patches, ordinary characters, and tragedies scattered throughout, but, by and large, gives the patient more room to be themselves, so that the relative equalization of roles in healthcare is more healthy, both for those who are cared for and for those who care. The implications for medical jurisprudence. The implications of this evolution of the doctor-patient relationship and the understanding of the illness narrative as the record of a journey are profound. It problematizes the episode, intervention, recrimination, or reward basis that fuels doctor-patient alienation and medico-legal adversarialism, adding warmth and lived reality to the idea of patient rights and questioning traditional positions to suggest a more restorative framework of health law and ethics. citing Grant Gillett and Georgina Richardson. Justice, restoration, and redress. Error, no fault, and tort-based systems. The duty of care becomes the duty to make a well-intentioned and skillful professional contribution to a two-way problem-solving venture, in which both parties are aligned, intelligent and willing participants. There are still boundaries and points of care and competence that remain in place, but the overarching orientation is to a shared venture in the midst of uncertainty rather than an unbalanced contract for service delivered more or less adequately. Decision-making and responsiveness become totally entwined in a non-linear way. Information is offered, appraisals of a situation shared, and questions responded to with a finely tuned or practiced awareness of the patient's state of mind and well-being. That openness also reflects the issues of confidentiality and inclusion of others, which in clinical life are commonly fraught with misunderstandings and possible or imagined transgressions. Some bright lines are in place, for instance, about imminent dangers to others or to the patients themselves, but other modes of information sharing and use are able to be negotiated with the best and most sustainable outcome for all, as the end to be aimed at, given mutual trust and an eye on the therapeutic aims. Disclosure and adversarialism are very limited in dealing with the apparent clinical impasses and misunderstandings. Patients can appreciate the uncertainties and difficulties when false hope is not given and information not withheld, so that shared and intelligent deliberation and plans of action are devised, acted on, and revised in terms of the events that unfold and the realistic outcomes that can be achieved. The likelihood of feelings of dependence, disappointment, and betrayal being part of the retrospective reflection on such a course of healthcare is therefore minimized with consequent personal, emotional, and physical savings to all. End-of-life decision-making is one area where unexpressed misapprehensions, emotional wounds, and disaffection surface. A trusted and yet knowledgeable companion who shares the journey, even when that journey is tragic, tends not to lose sight of such feelings, and therefore tends to avoid intensifying recriminations, guilt, blame, and hurt, the worst accompaniments of a patient's death. An evolved duty of patient-centered care and a responsive therapeutic alliance emerge from a deepened understanding of the evolving human reality at the heart of modern healthcare and ethics. The medical environment has come a long way since the artisan or journeyman healer formed a knowledge of and relationships with an individual patient and his or her household. In relation to that ancient healing relationship, much has changed and a whole system has evolved in which clinical services have accrued clinical bureaucracy, documentation and contestation of care, and a medico-legal apparatus of governmentality and structured dispute adjudication. But the caring art that lies at the heart of the Hippocratic tradition, suitably adapted to a contemporary world of shifting and dynamic human relationships and complex socio-political structures, can do much to make that modern and complex phenomenon far less bruising and alienating than it often seems to be. Stem cell tourism. From as early as 1992, clinics in unregulated environments have been offering treatments based on stem cells for conditions as diverse as facial wrinkles and autism. The promise has generated concerns in respect of health tourism from at least 2008, when people found that the portrayal of stem cell medicine on provider websites is optimistic and unsubstantiated by peer-reviewed literature. Others denounced stem cell tourism as driven by hope and pretense, and contend that, given the current state of knowledge, patients should continue to be counseled against medical travel for unproven stem cell-based therapies at this time. There is a proliferation of a number of stem cell clinics in different parts of the world, offering unproven stem cell therapies for a diverse set of conditions. Clinics are using a wide variety of stem cell types, including autologous adult stem cells and stem cells isolated from cord blood, aborted fetuses and early human embryos, and others with animal cells. Given the lack of regulatory oversight of these clinics in most countries where they operate, clinics may not actually treat patients of the stem cell type they claim, or even use stem cells at all. The underlying intentions behind the use of complementary medicine can also affect the definition. When it's used in place of conventional treatment, it's called alternative medicine. When it's used as an adjuvant treatment to conventional treatment, it is complementary medicine. When a treatment combines the best of complementary medicine and conventional treatment approaches, usually under one single practitioner or a coordinated team, it is called integrative medicine. The reality is, most is used concurrently with conventional treatments. Of course, how should it deal with the use of traditional or emergent evidence? Standard of care expected, as stated in Rogers and Whitaker, is that of the ordinary skilled person exercising and professing to have that special skill. And this may even apply for these unproven therapies where there is little evidence in practice. In the English case of Shakur and Situ, Justice Livesey considered the question of whether the same principles applying to Western medical practitioners applied to practitioners of traditional Chinese medicine. In this case, a widow of a patient sued a Chinese herbal medicine practitioner after her husband died after a course of herbal medicine treatment for benign lipomata. Although the herbal medicine treatment was, on balance, largely responsible for the patient's death, it was held that this was most likely to have been an idiosyncratic reaction that the practitioner could not have foreseen. However, as part of his deliberation, Justice Livesey considered the professional standards to which a Chinese herbalist should be held. After considering whether an unorthodox therapist such as this guy should be held to the same standards as an orthodox medical practitioner, he disagreed, stating, "The Chinese herbalist, for example, does not hold himself out as a practitioner of orthodox medicine. More particularly, the patient has usually had the choice of going to an orthodox practitioner, but has rejected him in favor of the alternative practitioner, for reasons personal and best known to himself, and almost certainly at some personal financial cost. Those reasons may include a passionate belief in the superiority of the alternative therapy, or a fear of surgery, or of reliance, perhaps dependence, on orthodox chemical medications which may have known undesirable short side effects, either short or long-term or both." Paragraph 416. It should be noted, however, that Justice Livesey also noted that peer professional opinion was valid in Chinese medicine because, even though it may not be viewed as a legitimate therapy by many, it adequately demonstrated a body of knowledge, noting, unlike some alternative therapies, TCM has a long and distinguished history. It is an oral tradition extending back some 4,000 years or more, and a written tradition extending back some 2,000 years. Paragraph 410. He did, however, hold that, although the TCM practitioner was not required to be held to the same standard of care, as part of the practitioner's scope of practice, it will often be necessary to have regard to the fact that the practitioner is practicing his art alongside orthodox medicine. This was taken to mean that the practitioner needed to be familiar with medical literature pertaining to Chinese herbal medicine practice, such as adverse events or potential interactions, in addition to their traditional knowledge base. These provisions are not unlike the provisions currently included in New South Wales and South Australian legislation relating to unregistered health practitioners, which requires that all unregistered health practitioners be held to the relevant standards within their professional group. but also require them to be familiar with orthodox medical literature and research on safety and ethics issues. Complementary medicine professionals are registered under the national law have to at least represent for and against arguments in an evidence-based and non-misleading manner. The Codes of Conduct says, good practice involves understanding the principles of immunization against communicable diseases. A case of continuing to treat when it should have been evident that a referral should have been made is Chinese Medicine Board of Australia and LIM. 2012 VCAT 1614, where the patient repeatedly presented to LIM with rectal bleeding, excessive bowel movements, dark stools, candy-like matter in stools, hemorrhoids, stomach pain and warm feet. LIM treated him with treatment he admitted was not clinically appropriate, and admitted he failed to refer the patient to a medical practitioner or hospital for further investigation of the bowel condition when it became, or should have been evident that the patient required such intervention or treatment. The same patient was treated at the same clinic by Yang. In that case, Yang admitted unprofessional conduct in relation to her failure to refer the patient to a conventional medical practitioner or hospital. After 12 consultations, when it should have been evident that the patient's condition had not improved and that the condition was a potentially serious one that was unlikely to respond to further herbal treatment.